So, good morning. I would love to introduce you to our speaker today, Dr. Tartaglia. Dr. Tartaglia is a cognitive neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and those with concussions who have persisting symptoms. She is a scientist and associate professor at the University of Toronto. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research and uses a multimodal approach that combines imaging and biofluid biomarkers to better diagnose and understand the pathological substrates that cause cognitive, behavioral, and motor dysfunction. The goal of her research program is to develop biomarkers for early detection of disease to bring precision medicine and targeted early treatments to her patients. So I am going to now turn it over to Dr. Tartaglia.
Welcome, everybody. Thank you for coming and happy Alzheimer's Month. I think it's a very exciting time for people in our field, and I think for the patients too, and their families, because there actually has been quite a lot of momentum in our field, and things seem to be changing. But obviously, there's so much more work to be done. So let's get started. So these are my disclosures. These are some of the grants, some of the companies that I speak on, advise, and some of the clinical trials in neurodegeneration that I am part of. So we're going to talk about the latest, but before the latest in Alzheimer's disease, but we're going to start with just an overview of, how we get to a diagnosis of these diseases. I think, one of the things that is very obvious in diseases like cancer is that, you actually need to have the right diagnosis to be able to get therapy. But in neurodegeneration, and especially in, Alzheimer's and those kinds of diseases, that concept is sometimes lost, which of course would mean it's very hard to get the right treatment. So let's start with a few things that, have come to be known and are really redefining how we think about these diseases. So, the way we think of a disease is you have symptoms, right? Like you wake up and you have like a runny nose, and that means you got a cold. And, a lot of times people don't think that that disease actually started before, right? And so for a long time, people thought that you got Alzheimer's disease the day that you started to forget things, let's say, but that actually is not true at all. And we'll talk more about that. But that idea is, important because when you think of treatment, thinking that there's a preclinical state, a pre-symptomatic state. And that is that this pathology builds for years, decades even, before we actually see any signs of disease, which actually is important for thinking about brain health even. Diagnosis is possible. Unfortunately, there are still a lot of people who don't get an accurate diagnosis of their degenerative disease, but it is possible, and that there are treatments now available. So this is, I think an important concept. So I'm going to spend a little bit of time. So if you look at that line on the top, which is this white line, you can see that's normal aging, right? That axis is years. So over time, when you get into your 80s, 90s, and 100, your memory is, your memory, your cognition, let's say, not just memory, but thinking, speaking, everything, might decline a little bit. Okay, so when you're 85, you might not be as fast and as, have a good memory as when you're 25, and that's okay. We expect that. But if you look at that yellow line, that's a line that is related to disease in the brain. It's not the line of normal aging. And the reason I stress that is because there's a lot of people who have complaints about their memory or their thinking or anything, and they are being told that this is normal aging, but actually that is incorrect. And if you look at that yellow line, at the very beginning, there's pathology starting, right? But the person's cognitive function is still really good. And they probably don't even notice, and certainly nobody else is going to notice any change because that's the beauty of the brain. The brain can compensate for that early pathology. So we call it a preclinical or a pre-symptomatic. You don't have the runny nose yet. Okay? But over years, decades even, you're accumulating pathology. So you could imagine that your brain is less able to compensate. And so at some point in time, you could have what we call subjective cognitive decline. So just, you notice something, but nobody else can pick it up. And then eventually you actually get what we call MCI or mild cognitive impairment. There's enough disease in the brain for you to have symptoms that can be detected by other people. And we do these cognitive assessments. And eventually, decades later, you end up with dementia. So this is happening over many, 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 many years. This is not over a year, well, over a few years. And this is the pattern for Alzheimer's that is very well studied and well known. But this is the pattern that we believe, and we have increasing evidence for, that is like this for all diseases. So the same for Parkinson's, the same for frontotemporal lobar degeneration, and probably other ones too. And so when we think of the disease of Alzheimer's, we have to think there's two pathologies of Alzheimer's. In the top picture, that's the amyloid plaque. And in the bottom picture is that neurofibrillary tau. So these are the two pathologies. They're different than what you see in Parkinson's, which is alpha-synuclein. And it's just thinking about cancer. Obviously, there's different types of cancer. Well, it's the same thing in neurodegeneration. And that graph, on the left there is something to show you that if you see that dashed line, the vertical one at 0, everything to the left of that is happening and is detectable, but there's no symptoms with that. And so things are accumulating and the brain is changing, but the person is still able to compensate and is functioning very well, is cognitively doing well, but the disease is happening. And in the analogy of cancer is that, you have this bad cell starting to replicate and is growing, but you're perfectly fine and you don't feel anything. And actually you could be running marathons, you could be working full time and doing all kinds of things, but it's still happening to the body. And so the disease happens for many years before you show clinical signs. Dementia, which is unfortunately all that we ever talk about, is, it's kind of a strange thing because dementia, all it really, really means is that you have symptoms that are severe enough, and they have to be cognitive or behavioral symptoms that are severe enough to interfere with your usual work, your social activities. There's a decline. There's, not a major psychiatric problem there. The impairment can be detected. It's not just you saying, listen, I'm not right. Other people can test you and find it. Could be changes in your memory or your judgment or your reasoning, could be a change in your visual, spatial, your ability to navigate, to speak, or to understand, changes in personality. But the issue is that this is not a diagnosis. This is just basically stating how you're doing. And the point of this would be that if somebody made a diagnosis of this, that then the next question is, well, what's the cause of it? Right? And unfortunately, where we end up stopping is that people end up with a diagnosis of dementia and nobody really even thinks of what the cause is. And so we think of dementia like this umbrella term that includes many different diseases. It is not the same as saying Alzheimer's, right? It's different than that, but Alzheimer's is a cause of dementia. Parkinson's disease is a cause of dementia. Frontotemporal degeneration is a cause of dementia. Lewy body disease is a cause of dementia. But also things like brain trauma and infection and multiple sclerosis and autoimmune diseases and stroke, all those are also causes of dementia. And so when we think of it, we're trying to think, well, what's the cause so that we could target the right bad protein that's building up? Because the proteins that are building up in Alzheimer's disease, they are not the same as Lewy body diseases or Parkinson's diseases or frontotemporal. So of course, in any other disease, you would think, well, boy, you have to know what the problem is, otherwise you can't treat it. Well, that's the same thing for our diseases. And, they all look very different. We call them all proteinopathies because they're based in proteins, but they all, these pretty pictures all represent different things. And so, again, this continuum is just about the disease is building up for decades. And then the point is that actually nowadays we can make the diagnosis before. We don't do that because the point of diagnosing is when you can actually have a treatment. So now we have a treatment for mild cognitive impairment and early dementia. So at that point in time, we actually do want to make diagnoses. So again, these are the amyloid plaque, those little things I showed you. The pathologies are building up in different parts of the brain and affecting your abilities to, do your proper cognitive tasks. And so when we think of Alzheimer's disease, we use these pathologies to arrive at the diagnosis, right? You don't want to, you can't say, well, somebody has Alzheimer's disease just because you have a bad memory. You actually should say if you have Alzheimer's disease because you figured out that they have those bad proteins that are building up in the brain. And we use those bad proteins to be able to tell us with some certainty what is the cause of your dementia. So Alzheimer's disease dementia is a specific type. So of course, you want to know that there's the Alzheimer's pathology. We often think of it as a memory problem, but actually that is not correct. It can present as a memory problem, but other diseases can also present as memory problems. And you can actually have Alzheimer's disease in the brain and have different problems. You can have language problems, so not being able to come up with words. You can have navigation problems, not being able to recognize things in space. You can have executive problems, so, bad attention or changes in your personality. You can actually have a motor syndrome, and it can all be caused by Alzheimer's disease. But Alzheimer's is a disease that affects 55, 56 million people in the world. And most of them, have a memory problem. And so we think of it only as that, but it is not correct to think that way. And when we think of, when people come to us and they have complaints, and we used to say, well, it's in your head, right? Like, we don't detect anything. You must be fine. But now we know that 1/3 of the people who have these early complaints without any signs that we can detect, they actually have amyloid in the brain and they are starting to accumulate this. And there will be a time in the not too distant future, I believe, where people will be screened. And when we see that these diseases are starting to accumulate, that there will be interventions for slowing down the disease, for slowing down the progression to a more symptomatic state. So the state before dementia, okay, if you think of cancer, you think, stage 3, 4 cancer is the advanced stage. But before you get to that, you have like the precancerous state, which is, you don't even have cancer, you just have bad cells. And you are, we could say that's the asymptomatic. But then you have like stage 1, 2. So early stages of cancer. This is actually when you want to detect cancer, right? So we have that too in Alzheimer's. It's called a mild cognitive impairment, not just in Alzheimer's, in Parkinson's also, in all the diseases. There's the mild stage of the disease, which is evident in other things. And these are people who have concern that there's been a change in their cognitive function. It's a detectable change. So when we test them, when we give them those memory tests, we see and we can detect that they're function, their cognitive function is not the same as people who are the age matched to them with the same education. They do have an impairment, but they are independent. Some of these people are working. These people are all around you. There's hundreds of thousands of more of these people than there are people with dementia walking around you. And these people are still independent, functional, contributing to society, living pretty good quality of life. They are not demented. And that we actually have ways of picking up the disease in these people also. And so when we think of Alzheimer's disease, we think of, this preclinical time, which you can see here is a long, long time. Things are changing, things are happening to the brain, but no symptoms. And then you have this mild cognitive impairment where, of course, more things are happening, but still you are independent. And then, there's the dementia stage, right? Which is a time where things are more severe. And also the dementia stage is a progressive disease, right? Like when you have early dementia, you're still able to do many things for yourself. And it takes a decade or, even more to get to a more advanced dementia stage. And so the reason I'm going through this is because when we think of therapies, right, most of the time when we think of treatments, we want to think of treatments that are going to stop the disease, slow it down, but you want to give those treatments to people who are in the early stages of disease because, in an advanced stage, maybe you don't want to prolong people's life if their quality of life is not great, right? So this mild cognitive impairment, also known as MCI, is where a lot of the treatments are targeting right now. And so we can make diagnoses. Traditionally, we have used clinical features, which is we ask you what's going on, we ask your families what's going on, but actually that is not great. We used to get it wrong a lot of the time. And so we are moving away from that. I would say that many people will say, yes, but I'm not getting investigated. My family members are not being investigated. And that is true because there are still barriers to this, but not because we don't have the technology, not because these things are not available. They are available, and we should be in a position where people are requesting them. So we have two different types of biomarkers in Alzheimer's disease. We're very fortunate. We can measure both of those bad proteins, and we can measure them in different ways. Cerebrospinal fluid, which is the fluid around the brain through lumbar punctures, imaging, blood, and of course autopsy. But the point is that we have many ways of diagnosing this before people die, and the same for tau. So one of the things that we can do is a lumbar puncture. We do it at the base of the back, below the spinal cord, and we can take the fluid and we can measure amyloid, and we can see that it's low when people have Alzheimer's disease. And if you look here, you can see that decades before, the amyloid in the cerebrospinal fluid is already changing to match that it's going up in the brain. And that is telling us that the Alzheimer's is starting. We have PET scans. This is positron emission tomography. It can measure amyloid. It's available in Ontario, but in a very limited number of centers right now, which will be expanded shortly. This is a very costly system, and so it is not available for everybody. There should be, really, high suspicion that a person has Alzheimer's disease to be given this test. And that, I think people understand that. It's the same thing for, a lot of the cancer testing. We don't do biopsies on everybody. We don't send people to nuclear scans for everybody with cancer because, of course, the system would be completely broke if, we did that. So we have to be quite judicious when we're using these kinds of technologies. We can measure tau, the same thing, through a cerebrospinal fluid. We can measure different types of tau. And so we can, the nice thing about a lumbar puncture or cerebrospinal fluid, although it's not as appealing as a PET scan, is that you can actually see the changes earlier on. So you could detect earlier stages of disease. And the same for tau. This is not clinically available. It's only under research. And so with these kinds of tests, we are very good at detecting Alzheimer's pathology. There is now a new test. It's a blood test. And I wish I could say that it's as good as the other tests, but it is not. I think many of us will not be willing to give disease-modifying therapies based on this test. But you could think of the near future when this test is really good and is available to everybody under like OHIP, let's say, like right now you got to actually pay for this test, that, when you got to a certain age, maybe you would get screened for this, right? Like you do for thyroid disease or, B12 deficiency. And that, if you had a positive test, then you would, proceed to different levels of investigation. And so this reality is actually very close at hand. I think right now what we're seeing is that it's not as good as the other tests. And, the disease modifying therapies that we talk about for Alzheimer's disease, they have a lot of risks associated with them. And so we wouldn't want to give them to people just based on a blood test. But yeah, you could think this is here now. This is not, the future. This is already available. It's just, undergoing improvements and needs to be OHIP covered. So this blood test is a protein that is linked to Alzheimer's disease, and it can identify early brain changes related to Alzheimer's disease. So how accurate is it? This is one of the issues that we're having, is that it can identify people who do have Alzheimer's disease, and 80% of the time it gets it right. So 20% of the time it got it wrong. And then it correctly shows many people with AD as negative, but 30% of people who had Alzheimer's disease actually were told they didn't have it. And so it's, that's good, right? Like, tests don't just appear. Tests evolve. Before you had your thyroid test available at your local Life Labs, it went through a lot of research and it went through a lot of testing until finally it got to a point where it was like great, where it is today. So this test will become great, but right now it's not as great as we would like it to be. So these are available at Life Labs and DynaCare. They are out of pocket, so not OHIP covered. The prices vary, and they are not Health Canada approved. So we are seeing that some people are getting these tests and they're actually not being used. They're not being assessed. So, there are what we call appropriate use of tests. And appropriate use of tests means somebody has to have cognitive impairment. You have to think that Alzheimer's disease is a possibility, and then you would get the test. But we're actually finding things going backwards where, people are getting tested and they should have never been tested, and then they don't know, and we don't know what to do with those results. So, there needs to be some education around this test. So let's talk about, why would you bother to get tested if you think you have Alzheimer's disease, and what's going on in the field? There's been a lot of debate in the recent years. Leqembi, lecanemab, this drug, which is considered to be a disease-modifying treatment, which is disease-modifying means it changes the course of the disease, right? Not a miracle cure, does not stop the disease, definitely does not reverse the disease, but has an effect on the course of the disease, okay? So this is the first one that got Health Canada approved. It took over 2 years from its approval time in the US. And I think Canada is the 51st or 52nd country of the world to approve it. So we were a tad bit slow, I would have to say. Approval by Health Canada, I think is important to recognize, does not mean coverage. So a drug can be approved by Health Canada, but the provincial drug plans can refuse to cover this drug. So far, Quebec has already given their verdict and they will not approve the drug for coverage. So the only people who will be able to get this drug right now in Quebec are people who can afford to pay the cost of this. And the insurance companies, we're not sure what's going to happen with them, but they may or may not cover. But the provincial plan is not going to cover it. For the rest of Canada, it goes through a different body. The verdict is not out yet. It'll be out, I think, in February. So people should look out for that. And if they have any comments on the decision, they should definitely make their voice heard one way or the other. So what does this drug do? This drug allows the clearance of some of these bad proteins. It only attacks amyloid. Okay, so I've told you Alzheimer's disease is two bad proteins, but it only attacks amyloid. Okay, and what it does is it allows the clearance system of the brain, these microglia, these are inflammatory cells, to get revved up and start to get rid of this stuff. So you could imagine that if you're only targeting one protein, well, you have to think of like you're definitely not going to get the whole disease out, right? But what effects do you see? So, oops, let's go back. So this is, I'm trying to stay on the right one. So what you see, this is the amyloid in the brain. So like I've told you, you can measure amyloid in the brain. So we can measure it with a PET scan. And the blue line are the people that got placebo. So they had no drug, okay, over 18 months. And their amyloid stayed about the same or went up slightly, which is what you would expect over time. The yellow line are the people who got the drug. So the amyloid decreased dramatically, right? So of course you can see there that there's been a big, big difference between the people who got the drug and the people who didn't get the drug with respect to their amyloid. This is what showed up as the, okay, you got the drug, you got that pathology out, but what does it mean clinically? At the end of the day, what you want to know is, well, does it change how I function? Does it change how I remember things? And you can see that the yellow line is the drug line and the blue line is the placebo line. And so I think there's two things that are very obvious. One, the yellow line still goes down. So that means people did get worse over time. This was over 18 months, okay? So one, the drug does not stop the disease completely, right? It still, the drug does something, but it does, the disease progresses. The other thing you see, though, is that there's a difference, a significant difference between the progression of the yellow line and the blue line, right? So it does show that there's a difference. If you got the drug, you're the yellow line, you progressed, but you progressed slower. You remained in a better state longer. And these are all types of memory tests or function tests. And so they all met what we call the primary endpoint, where it showed that the drug had an effect. Of course, we all want the miracle cure, right? We want to stop progression. That is the aim of everybody. But this drug does not do that. And, will any drug do that? We don't know. But the fact that we actually got what we call disease modification for some of us is already a big, great step in the right direction. And what it showed at 48 months, which was, something that we think is even like better news, is that, you could imagine a drug gives you a little change at 18 months, a little difference between the placebo and the drug. But maybe that change is always going to be this little change. But what they showed was that after 48 months of treatment, that difference actually became greater. And so people in the blue line, basically after 4 years of treatment, so not insignificant, 4 years, they did save themselves 9 to 12 months of progression over the disease, which, means that some people could stay in the mild cognitive impairment range, which is an independent range, for 9 to 12 months greater than if you didn't get the drug. And we don't know what's going to happen at 6 years, right? Because we don't have that data. This is all the data we have to date. So it actually made us feel better that this difference, which was small but significant, actually got bigger over time. And that's what we mean when we say disease modifying, is that you actually can see that there's a difference if you take the drug versus you don't take the drug, which is different than a symptomatic treatment, which is just that, big dashed line where you are, I don't know why it's so sensitive, but anyways, let me just go forward here. So not the top line, which is the disease modifying line. The second dashed line is the symptomatic treatment. You are doing better than untreated, but you will always decline in the same way. So that was lecanemab. It got approved. You have to be in the mild stages of disease, very mild. You have to have confirmed amyloid pathology, which obviously makes sense. And in Canada, like in some countries, they did not want to give it to people who are genetic carriers of ApoE44. It's kind of like, think of ApoE, different flavors of ice cream. You could have all these different flavors, but if you could have like vanilla and chocolate and vanilla and strawberry and strawberry and pistachio, but if you ended up with chocolate, you can't get the drug. And so that's something that we need to test for before people can obviously get the drug. And that's because there was a higher chance of having the side effects with that chocolate flavor, let's say. So when we think of what does it mean to get these treatments, and how does that actually relate to function? I think one of the things that people sometimes get confused about is, well, when can I get this drug? Like sometimes I'm referred people for drug trials and the person has severe dementia, and there are no disease modifying treatments for people who have severe Alzheimer's dementia. Most of the drug trials, just like this drug, are for people who have what we call mild cognitive impairment due to Alzheimer's or mild Alzheimer's disease dementia, which means you can do your instrumental activities independently. So you can still bank, you can still, take care of your household, you can do your shopping and your cooking. You may need a little bit of assistance, but overall, you actually are functioning very well. Like some people with mild cognitive impairment are still working. Yes, they make extra notes. Yes, they, have some aids in place, some strategies, but they are highly functioning. People can be, still volunteering and working with, their communities and doing all kinds of activities. They may need a little bit of help, but they have to be fairly independent, maybe just requiring a little bit of help. And it is detectable, right? It is a cognitive impairment that's detectable, and there actually can be neuropsychiatric symptoms that are included with that, but we have to, this is the whole point of doing an assessment, seeing what's due to what. But the drugs are really for people who have mild stages of disease. And, this is, one way we think of it, is this scale called a CDR scale. And, because it's always hard to say, well, what does it mean to be mild stage, right? Mild stage means for things like you have a memory problem, you have consistent slight forgetfulness, right? You can, remember most things, but you might repeat yourself a little bit. You are fully oriented, right? But you have some difficulty. Sometimes, you might miss the date or things like that, but you are most of the time fairly well oriented. You can have some slight problems in solving problems. You could, maybe there's been slight changes in the, activities that you do. But you are, you know, mostly doing your home and hobbies things, right? You're still able to do that. There's been only slight changes, and you are obviously fully capable of taking care of yourself. If you have a more mild form of the disease, you might have, you might often forget recent events, and these deficits actually change, like will affect your ability to perform activities, right? Like if you forget the day of the week, then you might not get to that activity that you're supposed to get to, right? You might have a little bit more problems with handling your finances, taking care of your house. You are maybe not as independent in your community affairs. And you need, maybe some prompting for your personal care. But still, functioning fairly well, with some assistance, able to do many things on your own, which is different from moderate or severe dementia, right? Where people become dependent. People really need somebody there supervising them, taking care of a lot of their daily function. And so, these diseases, these disease modifying therapies do need that you have to confirm amyloid pathology. Most of the time, it's done with cerebrospinal fluid and amyloid and PET scan. The ApoE testing, like I've said before, is for this gene that is absolutely required in Canada for accessing this drug. There's, like I said, different flavors of the disease. The different flavors are actually 2, 3, and 4. And the one that you can't have, so you can, and you get 2 of them, right? One from mom, one from dad. So you could have 2, 3, you could have 2, 2, you could have 3, 4, or 2, 4. But what you cannot have is you can't have 4, 4. The drug is infusion every 2 weeks. There's potential side effects. So there are what we call infusion reactions. That's, anytime you get infused with something, there could be some local reaction there, or you could have some, reaction like a little fever or something like that. But the ones that are worrisome are what we call amyloid-related imaging abnormalities. This is what, gets into the news, where you can have some inflammation or swelling of the brain, or you could have hemorrhage. And these are the most common side effects. And if you look, they were actually fairly common, right? Like in the trials, they were infusion-related side effects were the most common. But in the trials, we saw like 13% in one trial of edema, 24% in another trial, microhemorrhages, 17% in one, 31%. So this is not insignificant numbers, right? And that's why when we say to people, when we are giving a drug to somebody, you have to think of the cost benefit. Having bleeds in the brain, having swelling of the brain is not good, right? So the only reason that you would take those chances is because you think, oh, this is going to be worthwhile for me, right? I have the potential to have benefit. Just like if you get cancer therapy and you look at all the side effects, you think, oh my God, Oftentimes death is one of the side effects, but the the chance of benefit is what gets people to take those treatments. So it's the same kind of thing. These are not, your neocitrin and you might get a little drowsy. There's significant side effects to these medications and they need to be considered. One thing that's nice about the drugs themselves, and not just lecanemab, but even the other one, and we'll talk about it, is that it does seem that the rate of these bad side effects goes down over time. And so the worst of it is always in the first 6 months. The people who were most likely to get the side effects were the people with that ApoE44, so chocolate. And so that is why Health Canada has asked for those people not to receive the drug, because the rates of side effects was very high. And we can detect these changes. One of the things you may have heard is that these drugs need frequent monitoring. So you have to do multiple MRIs, and that's because you have to look for the swelling. You have to look for these little black dots. So here on this is those white patches. Those should not be there. On this brain is those little black dots. Those little black dots should not be there, okay, where the arrows are. And that's, the hemorrhages. They're small, but, you could end up with a big one. This drug is donanemab. In the States, it's called Kisunla. It is not available in Canada yet. It is under Health Canada review. So we'll find out in the near future whether it gets approved also. And it too has shown that it can remove amyloid very quickly out of the brain, and just like the other drug. And it has also shown, so the yellow line is the donanemab, the blue line is the placebo. And so that has, met all the what we call the primary endpoints. It does show that there is benefit to these drugs and that they can slow the disease, and that the disease modification actually increased over time. But we're not stopping there. There's a lot of hope that things are even going to get better, right? Like I showed you, the disease progresses. This pie is made up of all the treatments. This was in 2025. I'm sorry, it's cut off at the top. In 2025, these were all the drug trials aimed at Alzheimer's disease. So, lots of trials targeting tau, targeting inflammation, targeting all kinds of things. Nobody's given up the fight. We think we can do even better. And so this is all the activity that's happening right now. And what else have people discovered recently that I think is really important? Because these risk factors that have been shown to, let's say, accelerate your progression, get you to dementia faster. These are risk factors for dementia. These are things that people can work on when they're healthy. Well, I've told you, some people are healthy, but they have disease in the brain, right? And so, it's important to think about that, because there are things that we can do to slow down our progression to dementia, to slow down the disease manifesting itself. Things like physical activity. There's so much evidence that aerobic exercise, 30 to 40 minutes of vigorous activity most days of the week, can help with this. Not smoking, not drinking, things like brain injury. We know that brain injury can increase your risk of dementia. So avoiding, some activities that might put you at higher risk. Using canes if you're falling, making sure that if you're, walking around on ice, that you got good footwear, things that we can do. Making sure that we're social, making sure that we learn new things every single day, making sure that we, are careful about our weight. that our blood pressure is well controlled, that our cholesterol is well controlled, that, we manage our depression. These things have significant evidence that they can modify the course of the disease. And this doesn't matter what stage of the disease you're at. So it's important to think about that. This is just showing you all the evidence there is that, healthy eating, mental stimulation, physical activity, making sure that you're, what we call the cardiovascular risk factors like blood pressure and cholesterol and glucose are well controlled, really have a significant effect on progression of these diseases. And this was even showing, this was in a very large group of people, like 50,000 people, where they followed them up for 11 years, and higher activity related to frequent, vigorous, and other exercises, showed a lower risk of dementia. Oops. One thing I do want to talk a little bit about, and this is kind of, has become very evident, and it has implications for disease modifying therapies, is that oftentimes we have to think there's not just one disease in the brain. Unfortunately, there's more than one, many times. And that one disease of the brain does not prevent another disease of the brain. And so when we think about the future, there are probably going to be cocktails of therapies for people, because it's actually not that common for people to have pure pathologies. And so in this pie chart, you see, the gray are different types of diseases, and where it's, more pure in the sense of there's only one pathology. And that happens, in like, ALS, but not even all of ALS has only one pathology. And these are the Alzheimer's disease. And you can see the amount of gray is actually very little, because most people have a bunch of other things going on in the brain. And having more things going on in the brain is worse for you. It may speed up your disease. It may, make you have worse cognitive function, worse memory. And so, when we think about disease modifying and all those brain health activities, it's very important, because even if you're thinking, oh, I'm taking this therapy against this one thing, well, there's other stuff happening. And so you need to think about those brain health activities for all of the other pathologies. And so when we think of the future is probably going to be that you're going to take something against amyloid, you take something against another pathology, TDP-43 or alpha-synuclein and tau, and that hopefully we're going to get closer and closer to that straight line where people don't change over time. So to summarize, we actually need to start with the biomarkers. We need to make an accurate diagnosis to be able to give people any therapies, and that it is actually possible to do that today, and that we are actually now, for the first time in the history of Alzheimer's disease, truly in a time of disease modification. It's the first step. Nobody's going to stop here. There's a lot more to come. And with that, I say thank you, and open to questions.
So much, Dr. Tar. A lot of information, but really, really easy to understand. I think you've already talked about this, but I'm just going to ask anyway. So the first question is, are there tests that can detect disease before symptoms begin, decades earlier? And can those plaques present years before that they're showing symptoms?
Yes. So yes to both of those. The plaques are there 20 to 30 years before you show any signs of disease. That's why the brain is so fantastic. The brain can compensate for that. The brain has the ability to compensate for a lot of disease, but eventually it gets overwhelmed. It's, natural aging shrinks the brain. It's okay. We lose a little bit of our brains every year, and that's all right. But it starts when we're 30, 40 years old. So, over time, there's going to be like accumulating pathology and shrinking brain. And so our ability to compensate goes down. And yes, we can detect that those changes, especially with the cerebrospinal fluid, we can detect them like decades before. The point is that right now, because we don't give any interventions for that, we don't look for it, but we can detect it.
The next few are all medication related. So is lecanemab typically used in conjunction with medications that someone is already taking? I'm assuming for dementia or in lieu of what they're taking.
No, you can take it with the usual medications that we give for symptoms of dementia. So the acetylcholinesterase inhibitors like donepezil or galantamine or rivastigmine, you can use it with that. One thing that is important to remember is, so mild cognitive impairment, actually those drugs are not indicated for mild cognitive impairment. So many times people with mild cognitive impairment might not even be on those drugs. The only drug that we're not giving lecanemab to with is medications that thin your blood. So if you're on an anticoagulant, which is a drug that thins your blood, so people have atrial fibrillation, let's say, we don't give it because that drug increases your risk of bleeding, and lecanemab would increase your risk of bleeding, and that combination is not a good thing.
I don't know if you know the answer to this, but if someone was inclined to, how much does lecanemab cost out of pocket?
Right now, it's about, I think it's 32 or $34,000 in Canada a year. So not cheap.
Is Leqembi only useful for Alzheimer's disease
Yes.
to treat others?
No. You have to have Alzheimer's disease. Otherwise, it would be like you having, colon cancer and taking a drug that is only targeting lung cancer. You would be taking a drug that is completely useless for you, and you would be exposed to all the risks. So you have to have Alzheimer's disease to have this drug.
And then this is prior to having an MCI diagnosis. If you knew a parent or a sibling was already living with Alzheimer's disease, would a amyloid PET be appropriate to do? I mean, yeah, PET.
Yeah. So the scans and the cerebrospinal fluid, we only reserve them for people who have detectable disease. So you have to be symptomatic. Early stage, that's okay, but you have to have an impairment that we can detect. So it's not enough to say, well, I have family members who have Alzheimer's disease. No, because actually, if you have longevity in your family, the chance of having somebody with Alzheimer's is pretty high. Alzheimer's is very common. So we don't just go with having family members.
That is all the questions that we have.
Mhm.